Good evening, ladies and gentlemen. I'd like to express my special thanks to the organizing committee of the 5th Scientific Summit, and of course, special thanks to Mrs. Lina Nikolopoulou, who had the vision to organize this very fruitful conference. And ladies and gentlemen, before I will open my panel discussion according the evidence-based policy making, politics and society, the case of tobacco harm reduction, I'd like to share with you a few of my thoughts. Tobacco harm reduction. Definitely, tobacco is a very tough healthcare problem, personal and also public health problem. In theory, policies are based on facts and values, but they also must take into consideration governance, culture, pre-existing frameworks, and probably the color of the society. Regarding scientific issues, successful engagement in evidence-based policy making requires pragmatism that must be combined with scientific evidence and persuasion to translate complex scientific evidence into simple stories. How does this work at the level of European Union? To maximize the use of scientific evidence in health and public health policy making, what is important for researchers to do? What is important also for the policymakers and the politicians? How should scientists act when they defend the creation of a policy? How does this apply to tobacco harm reduction? Is there a tendency of policymakers to base judgments on their familiarity or knowledge or conceptions with the issue? I think that we agree with me that we need at this time very strong and long-term strategies and policies, but policies with a human face and not with a penalty or punishment face. What is the balance when policies are in the making? Are policies value-driving or evidence-based driving? What is compelling evidence for politicians? And with these few words and with the thought that in this panel discussion and in the whole conference, the end goal and the core remains a world free of smoke, I'd like to open this panel discussion with our distinguished panelists and speakers. Thank you very much, ladies and gentlemen. So I'd like to ask to start with Mrs. Maria Spyraki, a brilliant member of European Community, group of European People's Party, Christian Democrats, Greece, Nea Demokratia, and I could mention also a colleague of mine, because it's honor, because once journalist, always journalist. Mrs. Spyraki, the floor is yours.
Thank you. Thank you very much for having me in this high-level and very interesting exchange of views. Allow me to thank once again Madame Lina Nikolopoulou as one of the organizers heading this very important exchange of views. And let me start by introducing myself. My name is Maria Spyraki. I am a member of the European Parliament. I am serving my second mandate now in Brussels and Strasbourg. And I am here under my capacity as a member of the ad hoc committee, which is focused on the issue of beating cancer. The name of the committee is BECA. And that's why I'm here. And that's why I would like to start by saying a few words concerning cancer, which is one of the leading causes of mortality in the European Union, which is creating enormous suffering for European citizens. And let me introduce some kind of data which is important to take into account. In 2020, 2.7 million people in the European Union were diagnosed with cancer, and another 1.3 million lost their lives to cancer including over 2,000 young people. And of course, it is important to know and to agree that there is an urgent need to act now. If we don't, cancer cases are set to increase by 24% by 2035. And it is also tomorrow. And in this case, cancer will be the leading cause of death in the EU. So we are working on a key pillar, which is prevention. And prevention, according to the scientific data, we have to work because more than 40% of cancers, for all cancers, are preventable. This is the key word, according to my opinion. As you are all familiar, smoking is the #1 cause of cancer. However, smoking is still here as part of everyday life. Of approximately 26% of the overall population in the EU and 29% of young Europeans aged 15 to 24, and they smoke. It is 29% of young Europeans. And according to the Commission's poll, to the European Commission's poll, tobacco consumption remains the largest avoidable health risk in the European Union, and it is responsible for 700,000 deaths yearly. Around 50% of smokers died prematurely, resulting in a loss of an average of 14 years of life per smoke. And furthermore, there is a social dimension in this approach. Tobacco consumption is the leading cause of preventable cancer of 27% of all cancers attributed to tobacco. In addition, smokers are more likely to suffer various illnesses because of tobacco use, including cardiovascular and respiratory disease. And let's speak without any kind of exceptions. According to the WHO, all forms of tobacco are harmful, all forms. There is no safe level of exposure to tobacco. And in Greece, we have these negative championships. According to a specific barometer, Eurobarometer, held in February 2020, it was a survey in which we found that the highest smoking rate can be found in Greece, with the average smoker was 18.7 cigarettes daily, following second by Croatia, which is the average is 18.3, and Austria, which the average is 18. Tobacco use also another important social parameter on which I would like to ask you to take into consideration. Over 80% of the world's 1.3 million tobacco users live in low and middle income countries. And according to WHO, tobacco use contributes to poverty by diverting household spending from basic needs such as food, such as shelters, to tobacco. In fact, the economic cost of tobacco use are substantial and include high healthcare costs for treating the disease that they are coming from tobacco and the lost human capital resulting from tobacco attributable mortality. While lifestyle remains the key inequality dimension of lung cancer and the gender issue. Specifically in 2020, 22.3% of the global population used tobacco, and of them, 7.8% of the world's were women and 36.7% are men. The EU has been intensively working on tobacco control and protection from the hazardous substances, starting with the so-called BECA plan. It is the Europe Beating Cancer Plan to address the tobacco epidemic, which is an epidemic. And Europe's Beating Cancer Plan put forward actions from 2021 to help to create finally a tobacco-free generation, setting a very, very ambitious target, which is less than 5% of the populations that will use tobacco by 2040, compared around 25%, which is today the average. With the tobacco-free generation, we are moving forwards to a policy initiative to eliminate, first of all, the addiction. It is also the disease. It is the premature deaths caused by tobacco industry products. And therefore, the cancer plan, which constitutes a momentum to better enforce legislation in member states, national tobacco control strategies, especially as regards sales to minors, which is one of the important parameters we have to tackle, and campaigns on giving up smoking. And that will make for better implementation of the WHO Framework Convention on Tobacco Control, including the obligation of transparency and fully considering the principles of the Transparency Register. Additionally, at the resolution we adopted in the European Parliament at last February, February 16, 2022, in the plenary in Strasbourg. We are trying to facilitate heavy smokers to proceed cessation of smoking by using novel products which are under strict regulation. And let me elaborate further on this, because I think it is important. According to our resolution, we call to the Commission to follow up on the scientific evaluation of the health risk related to electronic cigarettes, heated tobacco products and novel tobacco products, including the assessment of the risks of using these products compared to consuming other tobacco products, and the establishment at the European level of a list of substances containing and emitted by these products, taking into consideration that electronic cigarettes could allow some smokers to progressively quit smoking, taking also into consideration at the same time that these cigarettes should not be attractive to minors and non-smokers. The minors in our resolution, the minors in our work in Becca, were at the core of our focus due to the problems that smoking is creating to the minors particularly. The idea is to call on the Commission to evaluate in the framework of the Tobacco Products Directive which flavors in e-cigarettes are in particular attractive to minors and non-smokers, and to propose a ban of those, and furthermore to propose a ban on all characteristic flavors in heated tobacco products and novel tobacco products. The EU will take tobacco decisive actions by reviewing the Tobacco Products Directive, as I have already said, and we will also proceed to amend and to update the legal framework for cross-border tobacco purchases by private individuals, which is one of the allow me to say, kerkoportes in Greek. Moreover, by 2023, the Commission will propose to update the Council recommendation on smoke-free environments by extending its coverage to emerging products, and also extending the implementation of this regulation to e-cigarettes and heated tobacco products, and expanding smoke-free environments, particularly including outdoor spaces, which is one of the issues that it is debatable, but it is one of the issues that it is in the pipeline and it is coming. In conclusion, and if we want to have finally a smoke-free environment, according to my opinion, we have to be much more proactive and much more creative than the period of time that we are now. We have pictorial health warnings, we have the ban on tobacco advertising, we have also taxes, which is still one of the main revenues when it comes to the member states. But I think that these solutions are coming from the past. And allow me to say that we have to consider update solutions. These kind of solutions are outdated. We have to rethink the way that we approach the issue of campaigns, and we have also to rethink the way that we approach novel products in order to facilitate heavy smoker. And we have to act together. We have to create an ecosystem. We have to have a partnership between the state, between the European Union, of course, first of all, but as you all know, health is a national competence. So we have to create an ecosystem on which the state, the stakeholders, the production, the civil society, and also patients, they are working together. And they are working together in order to first of all, to facilitate to quit heavy smokers, and then to create a model of the European life on which the smoking is outdated. Once again, thank you very much for having me here, and I'm at your disposal for further questions, particularly concerning Becca and the way we work on the issue of the evidence that we use. Thank you.
Thank you very much, Mrs. Thank you very much, Mrs. Spyraki, for your very fruitful and accurate statement. I keep some interesting points you mentioned. There's no safe level to exposure to tobacco. Definitely.
It is the same with alcohol, you know.
Yes.
It is actually the same.
Smoking and tobacco is epidemic. We know that. And we have to act together to create fruitful and interesting long-term strategies to act together for an ecosystem, for probably a sustainable ecosystem. so as to tobacco harm reduction. And ladies and gentlemen, we have to keep also in our minds that every year more than 8 million people die every year due to the smoking, and more than 1.3 billion people use every year the innovative tobacco products. Let me continue with Mrs. Zoe Dorothea Pana, lecturer and pediatrics, hospital epidemiology, infection control and prevention, School of Medicine, European University of our neighborhood, Cyprus. The floor is yours, Mrs. Pana.
Thank you very much. So good afternoon to everyone. First of all, I have to thank also from my side for the honor of the invitation. And it's really a great pleasure to have such a fruitful discussion about a very important and very hot public health topic. I suppose I was invited to come because I regard myself as a hybrid scientist. So from one side, I am a physician, but from the other side, I'm actually a scientific advisor at the Ministry of Health in Cyprus. So I have a dual role. And this was also very important to understand policy making and strategies. And I will focus actually as an epidemiologist today on smoking epidemics. I have the feeling that probably currently it's the right momentum, the appropriate timing to have this type of discussions about tobacco harm reduction and tobacco control. Not only due to increased public and stakeholders' awareness, but also because it's the appropriate time to leverage the existing clinical research infrastructure that we have created and invested for COVID-19 pandemic, a huge public health issue, and maybe to expand this infrastructure beyond COVID-19 pandemic, also for urgent and huge, actually, public health issues. We just mentioned the magnitude of the problem. We have to deal really with a pandemic situation if we take into account that still, after our initial improvement strategies, we have to deal with a public health problem associated with more than 1 billion active smokers globally, with more than 8 million deaths every year, which is, if you compare it also with the COVID-19 pandemic, approximately 1/3. It accounts to almost 1/3 of the mortality rates that are associated currently with COVID. So what I want to say is that we have to deal with a pandemic situation. And if we want to assess also the burden, the impact, the public health impact of tobacco use currently, we have also to discuss about chronic illnesses, multidisciplinary approach, and pragmatic approaches. So if I discuss from the perspective of a scientist, of course, we really do need evidence-based medicine, we really need real-world data, but on the other hand, what we have learned as scientists also from our experience during the pandemic is that we need realistic and pragmatic approaches. So we need to combine these two pillars. And of course, when we are discussing about public health policies or strategies, we need to see it as a continuum. So if someone asks us, until now, are we efficient with the smoke cessation strategies that we have adopted currently? So I think that according to data that we have on hand now, approximately 7 to 10% of active smokers really manage to quit smoking, which means that we need to improve our strategies and we need to be pragmatic. And I would like also to gain some knowledge from the COVID-19 vaccination. We all realized that it was very, very difficult to convince the public about COVID-19 vaccines. But I feel like that the most appropriate way to analyze and most importantly to communicate harm reduction or risk assessment is to discuss about risk-benefit analysis, which is actually the truth for any intervention, including public health interventions. So we need, with full transparency, to communicate comparable risk, and of course to see short and long-term data. So if we really have a more holistic approach and see the strategy as a continuum, then I feel like that we could not neglect the current evidence that we have on hand, but for sure we need to collaborate, I mean stakeholders, policymakers, scientific community, and have coordinated, harmonized actions in order to accelerate our knowledge. And of course, I would be more than glad to further elaborate on what we mean by accelerating knowledge from both sides.
Thank you very much, Mrs. Pana. Great statement, yes, indeed. So you mentioned that this is the right moment, the right time to, and at the appropriate time to talk and to plan some policies, all the sides about tobacco, regarding tobacco harm reduction, and regarding to novel products research and policy. And I keep in my mind, and I write down that we have more than 1 billion globally smokers, and probably it would be interesting to mention what about the kids, because we have also data for the kids, very tough, of course, young, very young smokers. And you mentioned also that there is 7 to 10% smokers that they want to quit, but they cannot.
7 to 10% are actually the active smokers that do manage to quit smoking.
Do manage, yeah.
So
it's not bad, this percent, I could say. But anyway, it's epidemic. And I think that we could take some lessons, as you mentioned before, from the management of the coronavirus pandemic to the tobacco pandemic, because I know that definitely the pandemic coronavirus someday will finish. I'm not sure about the pandemic of smoking. So let me continue with Poland now, with Mr. Andrzej Fal, the president of Polish Society of Public Health, Head Department of Allergy, Lung Diseases and Internal Medicine, Central Clinical Hospital, Ministry of Interior Director, Institute of Medical Science, Warsaw, Poland. Welcome in Greece, Mr. Fal, and we are looking forward to hearing you.
Thank you for your kind introduction. First of all, thank you for having me here, for inviting me to this summit to speak in several sessions. And well, good afternoon, everyone. First of all, every single speaker that I've heard here today is talking about the tobacco epidemics, about the amount of damage that tobacco smoking can make to our health, to our organs, and so on and so forth. I'm sorry, but would you please have a look at the banner of this meeting? We're talking here about the harm reduction, not about the smoking epidemics, because we all know, as we sit here in this room, that 8 million people are dying because of smoking, including 1 million non-smokers by second-hand smoking, and so on and so forth. We know that in the ideal world, we shouldn't smoke, we shouldn't drink, we shouldn't use sugar and salt, but the world is not ideal, therefore we do. But we have a good message coming. We have a good message that in most of these, wrongly explained lifestyle, we have harm reduction techniques. This includes also smoking, and this is why we're here. This is why we're discussing today. So let's the word stay with us, and let's spread it. And spreading the word will be the word of the day, because at the in introductory remarks, you were asking about the kind of policy being built at the level of researcher, of a physician, or of a politician. So I would say that the researcher is the most happy man in this trio, because he makes a hypothesis, he does research, either he proves the hypothesis or not, and he doesn't have to make any policy. Simply, the hypothesis 0 is either proven, and we have more facts, more knowledge in this on this subject, or it's not proven, so we stay where we were. Thanks God, and the researchers, of course, we have many facts now that show us that harm reduction in smoking really works. There are people, and I absolutely agree with them, who are saying, we need more evidence. But we will not have evidence if we not introduce this harm reduction technique widely, because only after a certain time we'll see the real life data, and the real life data always at the final verification of any, let's say, drug introduced. And we know that the introduction of any drug to the market is very complicated, takes a lot of trials, it takes a lot of research. Even though, after introduction, we have the real-life studies or real-life observation to verify if what we've learned in the trial is really working in the life afterwards. So if we decided to go this way, maybe this would be the way for appreciation of the harm reduction that we already have, and we know it's working, at least partially. But partially is better than not at all. When we move with the policy building, from researcher we step up to a physician. It becomes really more complicated, because a physician cannot use everything he has on his patient. He needs to have the evidence-based medicine, proven drugs, evidence-based medicine, proven techniques to introduce in the patient. Okay. But the physician is also he's a part of clinical trials, of clinical verification of something that the researcher previously verified out of a clinic. So we are at this step of evidence-based medicine building for the harm reduction, and we need to go this way. Either we confirm it in a couple of years, or we'll deny it, or we'll change it, or we'll stand somewhere in the middle. But we need to go this way, otherwise we'll never learn. Was it worthwhile or wasn't? So this is the attitude of the physician. And now is something about the politician. If I was to answer if the politicians, which kind of policy, evidence-based medicine, or based policy they're building, I would say none. And this actually could end the discussion, but let's go step by step. Why none? Because the politicians, they are responsible, let's say, for the next year budget, who are responsible for the amount of money that is will be spent next year on healthcare. They're not looking at the evidence-based medicine that much. They're looking at the budget, and they're looking at the amount of money they can spend having the budget closed. So I would say that the politicians have a very narrow window of planning. They have 4 years window of planning, because in 4 years, at maximum, they have the next election. So they need to be prepared. So I would say, with all due respect, that the only politicians who are really building some policy, health policy, access policy in that case, are those at the parliament. Because, the parliament is standing. The government comes and goes. The parliament, maybe not with 100% all the members, but the parliament as a body is standing. So the parliamentarians, they can focus to build the health policy for the future. And I think that from my point of view, 75% of my time is working with patients or supervising younger doctors who work with patients. So from my point of view, creating the policy, including the harm reduction policy, should be based on the parliament, either the Polish parliament or the European parliament, but on the parliament, not on the government, because the government usually says, okay, well, what can I do? I need money for the next year budget. I cannot promise you anything. So usually they do not promise anything, and they do keep their word. They don't give anything. So at this point, I'd say once again, harm reduction is something that we are here to talk about. Harm reduction is something that 20 years ago or 15 years ago was present only in drug abusers. Now we have harm reduction in cigarette smokers, we have harm reduction in extra offensive binge drinkers, we have harm reduction in those who sold or switched too much. We have several classes of harm reduction. This is what we did in the past, not even 2 decades. So let's stand for it and let's go further this way, because if we don't, as we look around, nobody would. Thank you.
Thank you very much, Mr. Fall. You're absolutely right that you mentioned that we need more database, and we have to speak finally with the people, with politicians of the parliament, and not generally with the government.
But if I may, there is a misunderstanding here, and I would like just to clarify. But allow me to say that the initiative coming from the European Union to first time in her history establish a specific and ad hoc committee concerning the way that we can beat and prevent cancer was a significant step forward. And it was under the result of the elections that they took place in 2019. It was the European election. It was one of the main priorities that we put in place. And it was before the pandemic. And by doing this, I would like just to remind to the audience that legislation, when it comes from the European Union, it is a kind of locomotive approach. And it is a locomotive in terms of the market, it is a locomotive in terms of providing predictability to the governments, and in terms of providing a roadmap to the member states in order to facilitate them to proceed with policies concerning public health. It's not our competence, but it is important to explain that we did our job. And we did our jobs in terms of working on beating cancer, particularly in terms of prevention. Yesterday, we had another announcement coming from the Commission on the issue of screening of people from different ages and varying on issues that they are exposed to dangers of cancer. And of course, we have to understand that it's now time to adapt also the issue of novel products, because novel products are facilitating heavy smokers, and at the same time, this kind of novel products should not, I repeat it, be attractive to the minors. So this is a kind of roadmap. This is the roadmap that we put in place. We did the job. We voted for it on February 22, yes, and now we are working in order to proceed with next steps. And we are waiting from the member states, which are responsible, and in this parliament you are right, the governments are responsible to adapt. The governments are responsible to adapt. The governments, they have to pay for this, but the governments, they have to adapt.
Absolutely, I do agree that creating such a committee was a step forward. Well, 50% of my patients are COPD patients, so I really know why do they suffer and how do they suffer. But, you know, the legislative initiative that, well, I do understand the way you need to go. I do understand that the acceptance of the country governments is required, but I need to say that my patients do not live that long. So they need something to be done.
But you have to put some pressure to your government.
To use what we have here and now, and maybe in the future the world is going to be better. We'll have better law, we have better cooperation, and now we do still better. But now we need to do what we can.
Probably Mr. Fall will have the opportunity later on to speak about the Polish model and how did finally you persuade the government
we haven't.
for reforms.
We haven't persuaded,
Yes.
that's why I'm so frustrated.
Yeah, that's right. sorry to interrupt you now. So, ladies and gentlemen, now we are wired, I think, with our next speaker, panelist, but virtual, in a virtual field, with Mr. Giuseppe Biondi Zoccai.
Hi, many thanks for this opportunity. I was supposed to come to Athens, but then COVID had me stopped here at home, but I'm almost recovered.
We wish you quick recover. Signore Zoccai, benvenuto.
Thank you. Thank you.
So, Mr. Zoccai is Associate Professor in Cardiology, Department of Medical Surgical Sciences and Biotechnologies, Sapienza University of Rome, General Secretary of SCORE. So, we are looking forward to hear you.
Thank you. I think we have discussed at length a number of important issues, and indeed, also thanks to this meeting, we have an ever-expanding evidence base. Of course, the problem is that some evidence is focused on short-term effects. Some evidence is coming from novel smoking products companies, and this may call into put a shadow of doubt on the quality of results, because the main drawback of a meeting such as the present one is that we are all a true believer in the benefits of modified risk products. But there are many people who are strongly against, and we need to find a way to convince them. Indeed, the problem is also that we typically put modified risk products as an alternative to smoking, or as an alternative to nicotine replacement therapy, whereas instead it would be more reasonable to consider them as an additional tool. I am a cardiologist, and I don't use aspirin as an alternative to stenting. I use them as a combo in a way. Also, this may depend on the patient features, on the presence of comorbidities and age. Of course, the elephant in the room is the risk of creating a new generation globally of people addicted to modified risk products. Because evidently companies may wish to push for this, so creating a new generation of people who use these new products instead of combustion cigarette products. And this is something that we need to be aware of, because it's the main drawback of any activity pushing for modified risk products in a risk reduction strategy. However, my recommendations can only be to act now based on the evidence which is available now, because if we wait for the evidence to be accrued in 10 or 15 years, we won't be able to travel back in time and make the key decision now. However, as a cardiovascular researcher, I think we need 4 types of studies now and in the future. Epidemiologic studies to monitor the risk of addiction in non-smokers, especially in teenagers. Randomized studies to test the safety and efficacy of modified risk products in apparently healthy individuals, as well as in patients with advanced cardiac, pulmonary, or vascular disease. And also in the future, in the unrosy scenario that we have people addicted to modified risk products, we need studies to test ways to discontinue these products in these individuals. And I leave this open now to discussion.
Thank you very much. Grazie, signore Biondi Zoccai. Grazie, tanto. So you mentioned that we create, finally, with the innovative tobacco products, a new addictive generation to these products. And we have to take care about this because, as I mentioned before, the users and the smokers of these innovative products are huge. The number is huge, more than 1.3 billion people worldwide. And I guess that in this number, there are a lot of young people, I'm sure about this. So with your fruitful statement, I think that I can start and I can open the conversation, our panel discussion.
If I may.
Yes, of course.
Well, addiction to new products being introduced to the market is always a big problem. When we look at this globally, not only at the smoking products, we have iPhone addictors, we do have binge watchers from the Netflix and other services. So the addiction is stuck, well, namely behind any product introduced to the market. The only question is the addiction as dangerous or causing health damages, or it's just, you know, a compulsory thing that we do as, by definition, the addiction is? So this is what you spoke before. It's the regular weighting the risk and benefits. So you need to look at both sides to have the answer. Secondly, I understand that the most important thing in introducing this harm reduction product in the smoking is that the addicts can be those youngsters. Well, my question would be, who sells these products to the youngsters and why? So this should be banned, and we have bans that we cannot protect. So let's ask our police and our other services that should focus on that and make sure that these products are not sold to those to whom they are not addressed. This is like, you know, the discussion about the excise tax about the recently in Europe. We cannot raise the excise tax because we create the black market.
Anyway, I'm sure that
I'm sorry.
addiction...
This is not an
addiction
argument.
is not a theory anyway, it's a way of life, I think. Mrs. Spyraki, would you?
Yeah, sorry, but I would like to intervene once again because I think that it's not the same level. And we cannot compare different things in terms of addiction. It's not the same, like my son has an addiction in Netflix by having an addiction in a novel product in order to quit tobacco. So, and that's why I insist on this. The proper legislation is the one that we have already provided under the beating cancer plan, which is at the paragraph 12, and which is also calling on the Commission to evaluate the way that this kind of novel products are reaching the market, the way that this kind of novel products are attractive to the minors and to youngsters, the way that this kind of products are finally resulting the reason that they are in the market. And I'm fully against on the issues of banning selling such kind of products, etc. We are living in a free market where the market is working, and also the evaluation of the Commission must be at time in order to ban some kind of perfumes that they are very attractive to the youngster. But it is something totally different. And I fully disagree with the level of addiction. It is not the same. Gaming, Netflix, and smoking, it's something totally different. Smoking is killing.
Psychology has a different opinion. It says it's all the same.
Netflix is not killing yet.
Oh, it is. It's ruined 90% of the social life of many people, especially in the US. So it's really a dangerous thing that we're looking at as a play, as a movie. This is socially a very dangerous thing.
You see, Mr. Zoccai, that you put fire in the panel with the word
yes,
addiction.
I think, my biggest fear is when in a panel is everybody's agreeing, because then we cannot convince anybody else outside the panel. I think we need to think about our enemies and also to think about the way evidence is generated and the policies are chosen. I give you an example. 20 years ago, I visited the US, a big hospital in New York, and was fascinated by the use of opioid painkillers there, which was much higher than the use of opioid painkillers in Italy. And I came back to Italy believing that in the US they were doing the right thing, and we were having people suffer without a need in Italy. 20 years later, we know that companies had to settle for several million of dollars for an excessive uptake among healthy people of opioid painkillers. So I believe that modified risk products are very, very safe, but they cannot be considered 100% safe. So we need to be aware and to track with research the use of them in healthy patients who are smoking, in diseased patients who are smoking, and also in healthy and younger generations, because otherwise we will be liable to be held accountable for any adverse events in those people.
Thank you very much. Mrs. Spyraki, as a member of the European Parliament, tell us a few words what now is happening in the European Union, and tell us about the Beat Cancer Plan, because fighting smoking is in the center of this planning. And we know that, as I mentioned, that we have more than 1 million deaths worldwide due to smoking.
Thank you for your question, and I think that I have already presented with some kind of details the next steps that we are proposing to the member states, and they are including in our Beating Cancer Plan report. But the case for me is first the implementation when it comes to the member states, how the member states will proceed with the Beating Cancer Plan report, and also, according to my opinion, we have to make some steps forward when it comes to Brussels as such, starting with the way that we use data. We don't have enough data, we are lacking of data, and we need compelling evidence as soon as possible. According to my opinion, in Brussels, particularly when it comes to the legislation, to the legislative proposals that they are engaging scientific issues, there is an evidence policy gap, which is not bridging with some kind of public hearings or else that we are organizing in order to have an overview, in order to have a sense of reality in our policies. So first of all, we need data, and we need to bridge the evidence policy gap. Second, we need to create the ecosystem that which I have already mentioned, which will take place with the collaboration of different parts of this situation, meaning that we need scientists, we need policymakers, we need the public society, and we need also patients. And by saying this, let me give you just two very, very brief examples coming from the UK, which not in the European Union, but it's also in a way leading the way when it comes to the way that they work in terms of bridging the gap of compelling evidence. The first one example is the James Lead Alliance, who has not been active on co-production of research agendas. And by saying this, it is a co-production of research agendas which involves patients, clinicians, and researchers. And the second one is the NICE, maybe you know the acronym, it is the National Institute for Health and Clinical Excellence in the UK, which is also makes research recommendation and priorities for nearly 2 decades, and the collaboration between different ecosystems and creating a whole ecosystem is a norm. So we have to adapt such good practices particularly in the member states such as our country Greece, in order to have the evidence and the compelling evidence we need to proceed with policies that will be implementable as soon as possible.
What are the weak parts, weak sides of the Greek example, do you think?
Implementation.
Implementation.
Implementation,
and which country is more focused to implement reforms and laws?
I think that all countries we face the same problems in the European Union, and my main message from this discussion is that we have to quit from the European way of living, the European way of life, from our trend, smoking. By saying this, I think that we have to make some kind of campaigns which are focused first to heavy smokers by facilitating them to quit smoking by using novel products, and maybe consider the way that we tax them. We have to consider this because it is important to have accessible products in order to facilitate them to quit smoking. And secondly, it is the youngsters that we have to explain to them that it's not the norm. It's not the trend, it's not cool. It's something outdated.
Thank you very much. Mrs. Pana, according to your very big work during the pandemic COVID, so you had all this experience. Do you think that we could probably follow some of the learnings and of the lessons of the pandemic coronavirus to the pandemic of smoking? And how can we persuade finally the politicians?
Very nice question, I have to admit. And I suppose, yes, definitely, because there are a lot of similarities. And since we are discussing about lack of evidence or lack of data, I think that probably we need to learn from the barriers or from the difficulties that we have encountered in evidence-based medicine or real-world data from COVID-19 pandemic and apply it in harm reduction policies and strategies. So I suppose one of the main issues was fragmentation of research. Secondly, lack of comparable data. So we need to focus on interoperability and reuse of data also for smoking epidemics and coordinated collaboration. So I felt like that, and I said also that COVID-19 pandemic was an opportunity because we had, for the first time also for the member states, a coordinated collaboration between different scientific consortia in order to accelerate high quality knowledge. And I couldn't agree more with Professor Zoccai about the type of studies that we urgently need in order to accelerate high quality knowledge also on that public health topic. And it could be, from one side, large-scale randomized clinical trials, I mean transnational, in multiple countries in order to assess, of course, efficacy, effectiveness, and safety of the new products that comes in the market. Simultaneously to randomized clinical trials, I feel like that large longitudinal cohorts in order to have real-world evidence is another very important step that we need to focus and adapt, I mean, from the scientific community. And at last, we have discussed also during the COVID-19 pandemic about public awareness, but probably also for the smoking harm reduction strategies, we need more engaged citizens. So coming from either patient advocacy groups or healthy citizens or even other citizens with chronic underlying conditions, we definitely need participation of the citizens in sustainable, for example, volunteer platforms to provide us with data in order to assess it with a standard methodology and increase the current knowledge. I feel like that this is the most important lessons that we have gained from COVID-19 pandemic: standard harmonized protocols and coordinated collaboration among the member states in order to accelerate transparently high quality scientific knowledge on public health issues like the one that we are discussing currently.
Very well. Mr. Andrei Fall,
Well,
what is the lessons of
fully-
your country, and are policies value-driven or evidence-based driven?
Well,
What is the case in tobacco harm reduction?
Speaking of a country's policy, I already mentioned that we haven't convinced those decision makers of ours yet, but we're working on
Beyond the
on
addiction.
that. Looking at the concept that we've discussed throughout this panel, that there's a different point of view of a researcher, medical staff, and politicians.
That's why there is
fully
interesting.
supporting what Zoe has just said, I would only add once again the physician's point of view, and the point of view remains unchanged. When you're dealing with a patient who is chronically sick, has one of the NCDs, the non-communicable chronic diseases, and these are life-threatening diseases. These are diseases that shorten our lives by more or less 15 years. So when we can use a medicine or a device of a proven efficacy that does one of two or both, either makes the health quality, the life quality related to health better to this patient during his disease, or makes the disease less severe and not so fast going. These are the two reasons for which a physician should always use the device or medicine if we have safety proof and efficacy proof.
Mm-hmm.
So we have already discussed that we need more proofs, but still we have some proofs and we need to follow this way, waiting for the political decision, for the plans, for the longer plans, but we can wait. Some of the patients need the help today, and this is the difference in my attitude versus any other, physician's attitude versus any other attitude. Otherwise, we agree.
Very well. Signore Zoccai, can you hear us?
Yes, I can hear you. I think
Would you like to mention something regarding to Mr. Fall answer?
Yes, I think we agree on the goals. It's a matter of finding the means. The Italian situation is not different from the Polish one, in the sense that the regulation so far on modified products is basically a regulation on the use. So it's similar to the regulation for other tobacco products. The key question is whether, for instance, we could provide some modified risk products for free to selected patients. For instance, a patient who is continuing smoking despite having had a myocardial infarction. That patient could benefit from having free access to modified risk product. But I think this is very, very challenging to implement, at least in the Italian system.
You're a cardiologist. May I ask you, what happened to people that try again and again to quit smoking and they fail?
I think they are a big black hole, in the sense that the hospital system in Italy is focused on acute care, and paradoxically we don't care about long-term management and patients once they've left the hospital. The problem is a smoker will have a need for a multifaceted intervention, and this can be provided only for few patients by dedicated centers. So the good thing about modified risk products is that they can be offered to anybody. They are not a prescription drug, but still there is the problem of information and cost and access to them.
Do you say to these people that are trying to quit the smoking and always they fail to start probably or to use innovative products of tobacco?
We routinely show them by videos, for instance, and we tell them, but it's not something that we do on a hospital-sanctioned basis. So it's our own individual clinical judgment, but we do recommend them, if they've tested and tried and failed other approaches, to use modified risk products. Actually, our recommendation is for a two-step approach. So first use heated tobacco products, which are more appealing for their thicker taste, and then vaping products. And then after that, after maybe a few months with each product, try to discontinue altogether.
Thank you very much. To the point. Before I close this, I'm sure that you find it very interesting panel discussion. Mrs. Nikolopoulou, can we take some questions from the audience?
Absolutely.
Thank you very much.
Are there any?
We have some minutes to take one or two questions. No question?
So you covered everything.
Do you think so?
We were so convincing.
You did.
We have some from online.
Can you sit? From Mr. Michael Verissa. I'm Michael Verissa, journalist from All Africa. My question goes to Zoe. From an epidemiological perspective, what is the picture regarding hospitalizations due to tobacco smoking-related conditions in countries that have adopted non-combustible smoking? Thank you, Michael.
Thank you, Michael, and this is actually a very nice question. I would actually add on that this is something that we need currently to address through the evidence that it's evolving, because at least from my side as an epidemiologist, I don't have on hand data related to your question. So this is also something that we need actually to ask to ourselves. What are the priority epidemiological research questions that we need to answer in order to convince also the stakeholders for that? I'm not aware if anyone else could answer to that, but this is something that we really need to address, in the following period. And of course, compare it also with hospitalizations from long-term smokers, long-term users of smoke, and compare them. This is something, a very nice research question to be addressed.
Thank you, Zoe. Some other questions, please? Also from here, from our audience, or... I think that we covered everything. That was it, ladies and gentlemen. Thank you very much for your attention. Thank you very much, my distinguished speakers.
Thank you.